The session was distressing symptoms in adolescence, and you did speak on dysmenorrhea. But do you think there are other things like prolonged amenorrhea, which can be also very distressing, if not to the girl, but maybe to the parents, and even prolonged bleeding, more of menorrhagia than dysmenorrhea? Would you like to say a few things on that?
Yes. Because of the talk time was this that much, and I was told to restrict to one particular thing. Yes, of course, menorrhagia means, in fact, what we call as AUB now, abnormal uterine bleeding. That's also very common, and that again, most of the time is linked to the AUB, the anovulatory cycles, where the periods can be quite long and they can sometimes come at very irregular cycles. That can be a very distressing symptom. Majority of the times, if there's no underlying pathology, after the first 55 cycles, the periods are supposed to settle down when the GnRH cyclicity sort of becomes more regular and the periods generally become normal. But if there is a problem, they should approach the gynecologist. And I think at this time, doing a hemoglobin and thyroid is always important, and an ultrasound to check out if there's any other underlying pathology. And of course, amenorrhea. Generally, by definition, if by the age of 14, a girl has not had her periods, we always say report
I'm
to
talking
your
of amenorrhea and PCOS. I mean,
in
prolonged
okay,
periods or
okay.
delayed periods.
Right.
More.
So in PCOS again, you can have prolonged periods of amenorrhea, and then suddenly, all of a sudden, the bleeding starts. But then again, I think in this situation, a cyclical control with low dose COCs would go a long way, and that would regularize the cycle. It may take 6 to 9 months before we can wean her off and allow that GnRH again to settle down. The amenorrhea does cause problems, a lot of bloating and premenstrual symptoms. But I think to regularize that again, we have to take use of the COCs. There's a role again here of dydrogesterone if it is used from day 5 to day 25. It can be used for a shorter period of time, maybe 6 months, to get that cyclicity in the cycles and to reduce the amount of blood loss.
Or even give it to them after 35 days so that they
Yes.
get at least regular withdrawal bleed, if not for a long period. Dr. Kanthi, you spoke, and something I learned something more about the doses of Myo and D-Cairo. I never knew this thing, but are they available in India?
Yeah,
It
now
is
they're
available.
available here.
Okay. My other question is, do you believe in combinations of Myo and metformin? What do you think on that? Because there's a lot of thing on that. Would you like
Actually,
to
I think you have
elaborate on that?
planned to put me in trouble.
No, 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 not at all.
I actually I give metformin and myonisitol too, and I have really got good results. But right now, I'm trying to segregate them. But there was a period when I used to, and nowadays they're not available as well. This combination, I think, is banned, right, Parikshit? Still, I think only one company has it. Only one company has it. All other companies have, yeah. Can I ask one question to Dr. I give. Can I ask one question to Suchitra, ma'am? Uh, it's not PCOS, I'm sorry, but it is dysmenorrhea. So these girls who get menarche around 10 to 11 years, and then after about 4 years, this girl develops severe dysmenorrhea and menorrhagia. And on sonography, because there's no other method of assessing, so abdominal sonography, they found that she has a bulky uterus, and mother's history is there of adenomyosis and endometriosis. And so what would you advise? Most probably it is a case of adenomyosis. So would you like to give her a combination of Dynogest along with the ocipil? I think there's one molecule now which is available, or would you just like to give her Dynogest with severe dysmenorrhea?
Yeah, I think before I jump to diagnosis, I would still like to start off. Yeah, first start off with the COCs or with the progesterone, and then because the diagnosis does have its side effects. There's a severe acidity which comes in. I know it's currently a wonder molecule, particularly when you're thinking of endometriosis and adenomyosis. But again, to prove or disprove that the pain is only because, and for a 10-year-old girl to suddenly have adenomyosis is not common. It's usually 14, 15, 16. So at that time, and I would, if she's having such, okay. Now 17, yes. Yeah, in those cases, yes. But I would still start off with the cyclical therapy first. If she responds well, symptomatic relief, if she's getting great, or then put her, because later on, I probably would reserve that molecule when the pain gets more severe. Because I don't want to do anything surgically. But many a times, with these girls, even with the dynogist, I mean, I have a 21-year-old like that. I don't have a younger than that. But I have put her on dynogist. And there has been relief of pain.
Well, I would like to add something around the story of metformin and inositol, since it's rather important to know that myo-inositol helps the activity of metformin inside the cell. So the question is the combination metformin plus inositol useful? The answer is yes, but you have always to keep in mind that if you have diabetes in the family of that lady, myo-inositol pathway is not working properly since the epimerase is depending from the presence of diabetes. If you have diabetes, epimerase is working less. So metformin uses a little bit inositol, but it can help the control of insulin without inositol. So the combination inositol plus metformin is really helpful. And if you add the combination myo-inositol plus dikiro, everything is working even better. So my opinion is always to check what kind of patients you have in front of you.
So to what she said, I mean, I wanted to elaborate on that to segregate patients. So for young adolescents, I think Mayo works very well. For the metabolic syndrome, it is Mayo with metformin will work very well. And maybe for the infertile group in the middle, it is Mayo with D-Cairo, which will work very well.
And I can add something that which is not yet in the literature since the paper has been submitted a couple of days ago. So something that I can report to you. This is an experience that we made with the assisted reproduction section in Pisa, and they made a double-blind study giving Mio plus Dikiro, just only Mio, and the results apparently seems to be that the presence or absence of diabetes is the key factor for the choice of the treatment. And on the other side, the idea that the keto is not so helpful for oocytes is completely wrong. So they found that the typical aspects and the evolution of the oocytes quality during the cellular division through the maturation of the oocytes are more effective using Dikiro than Mio.
Yes.
So this gives clearly differences when you think that inside the follicular fluid you have differences percentage of this in comparison to control. So probably we are missing something in the real pathways of the action of
Correct.
inositols.
Yes, and what I have observed in my practice is that most of these girls with PCOS, when we give them treatment for infertility and they conceive, many of them do have gestational diabetes, and we always immediately do a OGTT, and if I have given metformin or myoinositol, then I do continue. I do continue.
Can I just go back to that adenomyosis again?
Yeah.
There is also role of LNG IUD. Generally, we are not using LNG IUDs in nulliparous women, but there is enough of literature now to say that if they're not responding to the COCs or the progesterones, there is a role of putting in an LNG IUD. It may not give 100% relief, but over a period of time, at least it can give 50 to 60% relief.
Yeah, yeah. Yes.
I think if there are, yes, is there any question? Can you speak to the mic, please?
Hello, this is for Dr. Kanthi. Madam, I have seen also like myoinositol and metformin combinations drugs are available, but that is always SR preparation, metformin SR. So that, yes, ma'am, metformin SR and myoinositol. And this is because of my many absorption, like both drug are not doing well absorbed together because of that, or like why SR preparation?
See,
Like
I would not like to tell the name of the molecule or the company and all because it's a conference. But the ones which I use, it does not contain SR. No, no.
I think the SR preparations have generally come if people cannot tolerate a plain metformin. So that's why SR. But I don't think there is any other advantage on SR.
advantage on this. Okay.
Yes, please. Can you speak into the mic? Can you have a mic here?
to Dr. Pandit. One patient aged about 22 years. She is suffering from severe endometriosis, and I use OCP. On the other hand, she wants baby. So if I use progesterone instead of OCP, only progesterone, huh, will they be baby?
No, no. See, if she's got severe endometriosis and she wants a pregnancy, and if are you going in for the regular treatment, then you cannot use COCs, you cannot use Dynogest, you cannot use LNG-IUD. The options you have is dydrogesterone, ovulation induction, and dydrogesterone. And severe endometriosis conception becomes a little tricky. I would probably ask for an IVF
Now,
reference at that time.
After giving 6 months OCP, she is better.
Yeah, but then you can when you stop the
Yes,
OCP,
then
the
whether we
pain
can-
symptoms are going to come back. You can do an ovulation induction and try with See, with dydrogesterone, the advantage is it will take care of the endometriosis.
Yes.
It will not suppress the ovulation, and
Yes.
even if she gets pregnant, you still
It is safer.
continue.
But I can stimulate.
Yes, you can, of course.
Stimulate. Thank you.